Okay, go ahead. We are
Can you
live.
hear me?
Yeah,
I can't hear a thing.
I think. Can the audience hear me? Because we are live on
Just give me a
YouTube.
minute. I'll log in from the other device.
Yeah, everyone is audible, I think. Okay. So, guys, in today's masterclass, we are going to be talking about stimulation protocols, which are predominantly for unexplained infertility as far as IVF is concerned. Okay. And this is going to be a very short and sweet masterclass because one must understand that one of the most common people whom we end up stimulating for IVF are people with unexplained infertility. Okay. The problem or the advantage when you want to classify somebody as unexplained infertility is when predominantly all the reports which you state are absolutely normal. And when all the reports which you state being absolutely normal, still the couple is unable to conceive. Correct. So the husband semen parameters are almost everything normal. Wife has normal AMH, normal fallopian tubes, normal uterus. And usually by the time these couples come over to you, as you are aware, they would have done, 2 3 rounds, 4 5 rounds of IUI at multiple clinics, and they would have skipped and hopped doctors from here and there because the right type of doctor was not accessible. And many a times with unexplained infertility, what typically happens is the person who sees this patient the first is going to be the most unluckiest doctor. Okay, the one who sees this unexplained first, because that guy is going to try and follow the textbook, and he or she will try and tell the patient that okay, let's try with IUI, and the patient will usually end up doing maybe 4 cycles or 3 cycles of IUI with that doctor. Okay, and then there will be no result. So obviously, going by the standard scientific evidence, that doctor will be okay, then let's switch to IVF. And then instead of switching to IVF, that patient will switch the doctor, that array, this doctor is not very good. He tried 4 cycles of IUI on me. I did not become pregnant. Let me go to somebody else. Okay. And when this patient goes to somebody else with a hope that this other guy was also going to try IUI, it usually happens out of commercial interest that the other person will also try 2 3 cycles of IUI, and then halke se he will say, "Ki, okay, now let us do IVF." Okay, and then the patient switches again usually and goes to the third person. So the third person is the luckiest person as far as unexplained infertility is concerned. Okay, so with this much in mind, we will start off. Shilpa madam, you can hear us, right?
Yeah.
Okay.
Sorry. Yeah.
So with this much in mind, we will start off. I will go to the screen sharing. Okay, protocol for unexplained infertility. Otherwise, the very simple thing. Really, no rocket science involved. Okay. My signature is dark enough. So we are going to be talking predominantly of unexplained infertility in IVF. Okay. So friends, some prerequisites which you need to ensure: if AMH has been done for more than 6 months, then AMH is to be repeated for all of these patients. For the husband, DNA fragmentation index to be done mandatorily in unexplained infertility. Best outcomes will be obtained when DNA fragmentation index is less than 15%. Best outcomes for unexplained infertility in IVF will be obtained when the patient is of normal weight parameters. Severe obesity and severely thin patients, okay, are not going to be our point of interest in this particular thing, which is what is to be kept in mind. All right, fine. Now, we all know that otherwise the parameters are normal. Of course, the factors on which the entire stimulation for these patients of unexplained infertility is going to depend on the first criteria is age. If the age is less than 33, outcomes are good. If the age is usually more than 33, then the outcomes will follow age patterns irrespective of your protocol. Important for you to understand. Okay. Number of years of marriage. The more the number of years of marriage, okay, the more number of years of marriage, lesser is the outcome. Okay. Please keep that in mind. Number of previous IUI attempts. Now, this is interesting because usually these couples would have done anywhere between 6 to 10 IUIs. Okay, they would have tried everything. They would have gone and tried Ayurvedic, they would have tried homeopathic, they would have really done everything for unexplained infertility. Okay, fine. 4. Pre-treatment. Can you standardize pre-treatment for infertility patient? Answer is yes. You give pre-treatment GnRH antagonist. It is excellent. Okay. This GnRH antagonist pre-treatment is usually to be given approximately 2-3 days prior to your starting the treatment. Okay. What is the protocol which you have to follow? Now, commonly everybody will say that you should do antagonist protocol in unexplained infertility. But remember, antagonist protocol will give the same outcome as agonist, will give this almost same outcome as random start protocol. There is no difference in the outcomes of this entire things. Okay, absolutely no difference. 6. Can you standardize the dose of stimulation for these patients? The answer is yes. We almost always give letrozole 2.5 plus HPHMG somewhere between 300 and 375 to all patients of unexplained infertility. All patients of unexplained infertility. Trigger. Can you standardize the trigger for these patients? The answer is very simple. If you have more than 10 eggs, okay, then you give dual trigger. If you have less than 10 eggs, then in these patients you will be giving either 0.3 decapeptyl as a trigger, which is the best. Some cases you can also give 10,000 hcg. There is absolutely no problem. The outcomes will be the same, absolutely the same. No difference in outcome as far as IVF protocols are concerned. Okay. Any difference in the luteal phase support? The answer is no. The luteal phase support will be absolutely the same for all of these guys. No difference in luteal phase support also. So I will just write down any difference in luteal phase support. It is always going to be progesterone gel 8% plus dufastol. There is absolutely no difference in that. All right. Now, is there any difference which you have to do to the culture media when you have these patients of unexplained infertility? Some of the cases of unexplained infertility may be related to mitochondrial factors, okay, of the oocyte. As a result of which, culture media, when you select, you should try and select a single step media. Okay, this is important for you to understand. Day of culture. The best is to always do day 5, which is better than day 3 for unexplained infertility, because in unexplained infertility, you will have many cases of morula arrest. Okay, there is this entity which you will come to know, because fertilization will be excellent. Okay, division will be excellent. Day 3 will be excellent. It is between day 3 to day 5 that there is going to be a genomic shift. And in some cases of unexplained infertility, the morula arrest because of a defective genomic shift. Okay. Can you use time lapse imaging to enhance the outcomes of these patients? The answer is no. I personally think it has got hardly any benefit in expanding the outcomes for these patients. Okay. It has got hardly any benefit. 12. Is there anything which you can do separately in the culture system? Okay, so the answer is, it is believed that patients with unexplained infertility, embryos, when kept in co-culture, okay, will do better than embryos kept in isolated culture. Okay, though scientific evidence may be variable, this is the thing. Anything which you should do as far as the size of droplet is concerned. So remember, the size of droplet between 20 and 30 microliter to culture 3 embryos is considered to be good. Okay, try and avoid exceeding more than 100 microliters, as it becomes too big a droplet and there is dispersion of autocrine factors if the droplet size increases. All right. Which is the incubator which is going to be better for culturing patients for unexplained infertility? The answer to that is a benchtop incubator. Okay, the benchtop incubator would really give you great culture conditions. Okay, uninterrupted great culture conditions, and as a result of which benchtop is good, because benchtop is also good when you want to go to day 5 embryos. Okay, if it is day 3 as your standardization, which it should not be, then even box type incubators are good. All right. Is there any role of using adjuvants like embryo glue or laser assisted hatching in patients of unexplained infertility? So the answer to that question is that practically there is no benefit. All right. So I will just write down, there is no benefit of embryo glue. There is no benefit of additional hyaluronan. There is no benefit of cumulus assisted transfer, and there is really no benefit for laser assisted hatching unless the age of the patient is more than 37 years in patients with unexplained infertility. Okay, so I guess if you understand these many things, then majority of the aspects of unexplained infertility, which as a doctor you need to know clinically as well as embryologically, are finished. But if there are some more questions, I shall be happy to answer. Remember, always in unexplained infertility, frozen transfer is better than fresh transfer.
Yeah. Do you see for all unexplained infertility, what would you counsel the patient for? I mean, do you counsel them like you will?
So we have a wonderful line of counseling. I'll just share it with you. See, we always, it is very difficult or it is very easy to convince a patient of unexplained infertility. The best thing which you can tell very honestly to your patient is that there are so many factors in fertility, okay, which do not even have a testing. Right? You can only test for semen analysis, AMH, PSH, prolactin, nature of fallopian tubes, and 3D ultrasound of the pelvis. But there are so many more factors. For example, let's say acrosomal reactions, like I mentioned about the genomic shift. All these factors could be responsible for unexplained infertility, especially prolonged unexplained infertility. And because we don't know so many tests, we don't know which is the exact factor which goes wrong in that particular patient. And because we don't know which factor is going wrong in that particular patient, the reports which are available are normal. And there could be so many things which are unavailable and untested for which are abnormal, which is why IVF is the treatment of choice, as IVF literally eliminates, let's say, 7 to 8 other factors which otherwise we are dependent on the human body. Okay, which is why I think if you counsel it this way, then it is one of the best ways to counsel. One more thing I just want to mention about unexplained infertility in our country, okay, is that one must rule out chronic endometritis even when the endometrium looks to be absolutely normal, because endemic tuberculosis is very common in India, okay, and people miss out on that diagnosis and ultimately end up not getting the outcomes.
Yeah. So this is a condition where many people will under diagnose or overdiagnose unexplained infertility. And I think you mentioned the few tests that you would do. So what are those 4 tests that you would do? And if you think that is normal, you stop it there.
Means?
Like say DFI. So there is, you have done these 4 tests or 5 tests, and if everything seems to be normal, then you label them as unexplained infertility.
Correct.
So what are those tests in your practice that you would do to tell that, I mean, after this, I don't really bother doing the tests?
Sperm DNA fragmentation morphology index,
Mm.
AMH, PSH, prolactin, 3D ultrasound of the pelvis.
Yeah, I think so. I think that's important wherein we don't have to do a chromosome analysis. We don't have to do with a hysteroscopy, or we don't have to really have a laparoscopy to say that it is unexplained infertility, right? Or you think it's a very individualistic thing to about.
Very, very individualistic. I would just like to add a point. When you have unexplained infertility, do two things: do a per specular examination and do a per vaginal examination. Okay, this is something which majority of the fertility centers don't do. Okay, they will miss out on chronic cervicitis, they will miss out on PID, they will miss out on chronic PID, they will miss out on small cysts, they will miss out on restricted mobility of the uterus. All this no is not going to be picked up on your routine transvaginal ultrasound. This will be picked up on PS and PV, I think, and you must do it.
So how do you treat your cases with chronic cervicitis? What is your line of treatment?
These days, after giving antibiotics, okay, as a primary course, we have started giving placentrex. It is very good as long as the colposcopy is normal. And we have also done more than 40 cases now this year itself of injecting cervical PRP. Okay, it is something which is good in chronic cervicitis, which is non-infective, as long as the high vaginal swab is normal.
So do you suggest to try with this IVF light or say low dose protocols and
No,
unexplained activities? And
no.
okay, so sometimes the couple will come and say that, okay, I mean, my mother conceived after 8 years of marriage, so should I really do something about I'm already married for 7 years. Should I just wait, or should I go ahead with treatment like an IVF? So you think it is genetic, wherein like I think there is the asynchrony between the endometrium and follicles or maturity of the endometrium, which can I mean, as age advances, that kind of synchronizes. Is there a theory that you believe in like that?
There was no WhatsApp 25 years ago. There is WhatsApp since the past 5 years. So as times change, these types of things change. But yes, patients are very, see, if they don't want to do an IVF, no, they will give you the most stupidest of the reasons. Okay. The commonest reason which I get is in my clinic is the doctor is too busy and he does not do personalized ultrasound for the patient. Okay. So that's okay. Abhi, can't do much.
So what is your take on this peritoneal endometriosis in cases where it is unexplained, wherein there are no symptoms of endometriosis? There is a patient.
Honestly, we will only try it, madam, if there is a poor egg quality or a poor embryo quality in unexplained infertility. That is when we actually learn to pick up peritoneal endometriosis, do a CA125 and all these types of things. है ना? Otherwise, you will not pick it up. It is not easy to pick up.
So, in your practice, what is the commonest reason for unexplained infertility? Is it chronic endometritis, or is it something else?
Idiopathic.
So this idiopathic, I mean, I think we should talk about it a little more. In your experience, I mean, is it a de novo thing? Is it a patient factor? Is it something related to the patient's genetic makeup? Or it is between the husband and wife, wherein when the oocyte looks okay, the sperms look okay, but when the embryo is formed, it doesn't look that great.
Maybe. When the embryo is formed, it doesn't look that great. Rest of the things are very good. I also don't know, madam, if it is just related to that particular couple or not. I don't know. Because I have never had somebody in whom, I mean, I have never told anybody, go get married to a different wife. I have never, I don't know only anything like that.
Okay, so do you change anything in that couple in the subsequent cycle? So in the first cycle you have tried, they don't form good embryos. And then in
Yeah,
the subsequent cycle, I mean, I know you don't do donor program. So, and
yeah,
this is a valid reason to do a donor program. So
yeah.
after how many cycles do you give up and say that, no, I mean,
Three.
after 3 cycles,
Yeah.
and how do you counsel them, as in, like, what do you tell the couple, like, why it was not successful, as in terms of like embryo formation?
Madam, it is one most of the times in embryos, you will come to know the stage at which it is getting arrested and you will have some clue. For example, if there is no fertilization, there is a sperm factor. Correct. After fertilization, if there is degradation, then there is an oocyte factor. If the granular cytoplasm is very granular, then it is an oocyte factor. If the packing of the ooplasm and the sperm has not occurred, again it is an oocyte factor. If the division is there but division is unequal, that means it is an aneuploid embryo in the first place to start off with. If there is too much fragmentation, then the incubator is not good. If there is nothing and the embryo is gone up till day 3 very beautifully, and after day 3 there is a sudden morula arrest, that means there is a problem in the oocyte, because till day 3 it will grow something related to the oocyte. You can have embryos, for example, if it is just a day 2 arrest. Okay, for the embryo to go and fertilize and do the first division, even if you switch off the incubator, it will go and divide, because that much amount of energy it is present in the oocyte itself. Understanding? So let's assume after day 2 it has arrested all the embryos. That means there is something wrong in the incubator. After it has formed morula and not formed blastocyst, that means the genomic shift has not occurred. In that situation, maybe you can do a karyotype of the couple in the next cycle and then go ahead with the embryos, I mean, with the formation of embryos. So there are, I mean, studying the embryos is the most in a controlled, standardized laboratory environment. Okay, it is going to be something which will give you a lot of clues for the next cycle.
So if you have done an ICSI and if the embryos are not formed, so do you advise the patient to go for an IVF in the subsequent cycles in unexplained infertility, or do you do half and half, like you do half of IVF and then half
No, no,
ICSI?
no. See, in ICSI, if there is no fertilization, okay, then usually there is something in the sperm. Please understand. Okay, mostly it can happen with testicular sperms. I don't know how many of you have experiences of doing microtisa sperms ICSI. It is dangerous. You can have like 10 oocytes and you think you have 10 sperms and only 5 will fertilize. Okay, so it is a sperm factor 100%. And the next cycle is very easy. You should aspirate testicular sperms. Simple.
So what is your experience with fragmented oocytes in unexplained infertility? I mean, do you get it
Common,
often?
common,
Uh,
common. And it is not drug related. Let me tell you, it is common and it is not drug related. Both the things.
how do you differentiate? Do you change the drug the next time? Like if you are using HMG, do you change
No,
it to Recomb
no,
FSH and then
no, 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 no.
yeah. So then how do you say it is not drug related? Is it like you have a batch and you have quality control?
No, I'm just telling you from my experience that any form of granular oocyte is not a drug related thing.
Okay, okay. And what about sticky cytoplasm? I mean, do you see it as a
Oocyte
drug?
factor,
It is just a oocyte factor?
100%.
See, but many a times in our practice, we see back-to-backs, like see three cases of fragmented oocytes back-to-back. Like there are brown oocytes, dark oocytes. There are oocytes like which have sticky cytoplasm. So in such things, I mean, how do we like say that it is because of the patient factor and not
In
because?
order for you to say that, you will have to be using a particular brand of a molecule for a prolonged period of time. Okay. Majority of the IVF centers, what happens is, uh, you know, there is a quarterly shift in the company from which the HMG they will be buying. Okay. So that, I mean, I don't like to do that practice that way, but I think that practice should be discouraged.
So in cases of unexplained infertility, so do you recommend doing a particular protocol? I know you said antag is equal to agonist is equal to the random start, but do you have a preferential thing when it comes?
Random start.
So you think, I mean, it gives a better quality oocytes or
It will give you, if it will give you that one number less, but it will give you that, it will give you an outcome. This is what I have seen.
and in cases of unexplained infertility, so you have two sets of patients, like the ones who have multiple cycles of IUI and they come to you.
Yeah,
or they have like multiple cycles of IVF and they come.
IVF,
Yeah.
correct.
So in IUI, I know whatever you said holds good, and I think you have covered everything over there. In IVF, so they form great blasts, and you have transferred in an excellent endometrial,
Endometrium.
and still it doesn't work. Okay.
Rule out chronic endometritis and do PGTA.
So what is your take on PGTA? When would you advise? Is it like, after one IVF failure or after two
Two,
IVF failure, or is it only two
two,
IVF?
two.
And what about the age factor in these situations? Do you always consider age, like two younger patients? See, you see a patient of, say, 25-year-old, but married for 7 years with unexplained infertility, having had like 7, 8 IUIs already. You have the same situation at the age of, like, say, 35, married for 7 years with 7, 8 IUIs failed. So do you change your protocol when it comes to this thing? Like, do you offer them extra? Do you tell them,
No,
like, going to do a laser assisted hatching, I'm going to do nothing at all?
no, you should not change.
Okay. And in which situation do you go for fresh embryo transfer? I know you said frozen is better in unexplained infertility. Which are the situations that you think, like, the fresh embryo transfer can benefit that patient?
Only if they are international patients.
That will benefit you, not the patient.
Yeah, but only if they are international patients, we'll do fresh. Otherwise, we don't want to do a fresh transfer.
Not at all.
No, I'm not
And
for it.
okay. And what about the chances of empty follicles in these true empty follicle syndrome in these situations where there are no oocytes retrieved?
It can happen, madam. There is no question. There is no doubt.
And do you think that, like, in unexplained infertility, the stimulation, the way it goes, is there any change? Like, it doesn't, the response is suboptimal. In what percentage of cases have you seen that the response is not optimal? Like, they take longer duration for stimulation, or they take more dosage of the HMG?
No, no, no. It will almost be the same.
Yeah, I agree
They
to
are,
that.
they are normal responders, madam.
Yeah. Um, oh, okay, I think, yeah, and TVOD, I think that's your this thing. So, what is your take on the role of TVOD in unexplained infertility? Do you do it only when it is low AMH, poor embryo formation, or is it like for unexplained infertility who have had good blastocysts also in the previous IVFs and still have not conceived? You would do a TVOD and then take them up for IVF.
We'll have a class on TVOD sometime in June.
Oh, in June? Okay, sure.
Yeah.
Sure, I think, yeah, I think we have covered most of it, I believe. I know we can go on talking about it forever, but I think we should put a stop somewhere and we'll discuss the rest on the WhatsApp groups. Thank you so much. Thank